Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium. Please remember to fill out the program evaluation, and please keep those suggestions regarding future topics and future speakers rolling in. Today, it's my pleasure to actually reintroduce Dr. Ricardo Arbulu. Dr. Arbulu is board certified in internal medicine and infectious disease. He has been a frequent and excellent contributor at Grand Rounds, and he's here today to update us on antimicrobial stewardship here at Mary Greeley Medical Center. And please join me in welcoming Dr. Arbulu. Thank you.
Hi, thanks for having me. Can you hear me well? All right. Trying out the pop star mic. Okay. So our goal today is that people become familiar with antimicrobial stewardship. What is antimicrobial stewardship? Well, first of all, it's something we have. Something that has been in place in Mary Greeley since September 1st. The Infectious Diseases Society of America, the Pediatrics Infectious Diseases Society, and the Society of Health Epidemiology define antimicrobial stewardship more or less the same way. This is a systematic institutional intervention designed to achieve optimal use of antibiotics, with the ultimate objective of achieving the best clinical outcomes. That's always the #1 objective. Limit selective pressure, which drives the emergence of multi-drug resistant organisms. Minimize adverse events, including C. diff, and reduce costs associated to inappropriate antibiotic use. So we'll go over this, and my talk has two parts. In the first one, we'll review why this is important, why is this relevant. And in the second one, we'll bring it home to Mary Greeley as of what is happening and how it's happening. So when, as you know, Alexander Fleming is credited with discovering penicillin and introducing it to clinical practice, causing a revolution in medicine. Actually, people could be cured for the first time for many diseases. And when he accepted his Nobel Prize, he said these words that at the time may seem like a naive or innocent remark, but now have become a prophecy. So you can read it there, but what he was saying was, at one point, if we use antibiotics in a non-judicious way, what we'll do is, instead of curing disease, causing the bacteria to become resistant. And at one point, well, I'm reading beyond that, it'll come a time where we run out of antibiotics. So he said that at the beginning of the antibiotic era, and apocalypse is here. The CDC has now all these 3 different levels of hazards labeling for multi-drug resistant organisms. And it's worth looking at 2 of the guys who occupy this highest level of urgency. One of them is Carbapenem-Resistant Enterobacteriaceae. These are strains of either Klebsiella or E. coli, both bugs that we encounter in common practice, but that possess a particular genome sequence, generally in the form of plasmid, not in the main chromosome, but some genetic material that can be easily, promiscuously transferred from one bacteria to the other, that by definition confers resistance to carbapenem, but it has a certain mechanism of resistance that allows it to promptly develop resistance to other antibiotic classes. So what we're looking at here are bacteria that quickly become resistant to all or nearly all available antibiotics. And the time that when we said, okay, apocalypse is here, was during this infamous 2011 NIH outbreak. An index case was identified with CRE, and about 30 days later, people started dropping like flies from CRE infections. The index case had a CRE that was susceptible to, was resistant to most antibiotics, but it was susceptible to a few. Cholestymitate, or colistin, an old antibiotic that has recently been resuscitated to be able to treat these resistant infections, an aminoglycoside, and tigacycline. Just those. By the time the last patient died, that patient died because there were absolutely no antibiotics that could treat his infection. So this is the post-antibiotic era right here. And it is virtually in all states of the Union, including Iowa, including in Mary Greeley, where we had one case in 2011. Fortunately, this patient was just colonized, so he didn't die from this. And by the way, clarification for those who are reading into this, if an E. coli or a Klebsiella is resistant to carbapenem, it doesn't make it a CRE. It has to have these particular genes that actually are mentioned in the next slide, KPC or NDM, that confer this particular type of resistance that allows it to develop resistance to other organisms, other antibiotics pretty promptly, and B, be easily spread horizontally, like spread to other bacteria. It is illustrative for the purpose of this talk to look at the risk factors. So CRE is definitely and clearly associated with cephalosporin and carbapenem use. That seems intuitive, but is verified empirically. These are, by excellence, healthcare-associated infections. You don't run into a person on the street with CRE. And they are seen, interestingly, more frequently in long-term care facilities than they are in hospitals. So this illustrates the first point, the need for judicious antibiotic use, in particular of these classes. B, the impending need for improved infection control within the hospital to avoid horizontal transmission. And C, the importance of the continuum of care. Everybody needs to be doing stewardship, everybody needs to be doing infection control, because, well, we may do great in this hospital, but the other hospital is sending people with CRE to the nursing home, and they will eventually end up here. So, point well taken there. These are other facts on the epidemiology. Now, not only we're having worse bacteria, the pipeline of antibiotic production is drying out. And this situation has been termed by the Infectious Diseases Society of America with the brilliant name of Bad Bugs, No Drugs. That was the name of a report that came up in 2004 and still holds true. And you can see here all the enthusiasm of the pharmaceutical companies simply drying out in the 80s and 90s and then struggling to come back in later years. This slide illustrates the same point with a different graph, and also makes a point that the public has taken notice, because you know where I took this from? It's from Men's Health. But here's actually the reference, Clinical Infectious Diseases, and actually is from Men's Health. And our journals are not as colorful as this. So the second guy that is up there in the urgent level of threat is C. diff. This is everybody's friend. C. diff, I don't need to speak a whole lot about what the bacterium entails, but it causes, it is calculated, estimated to cause 250,000 infections per year in the US that result in 14,000 deaths and $1 billion in excess medical costs. So, of course, we use antibiotics judiciously because we're trying to prevent C. diff and CRE, right? Not. 20 to 50% of the antibiotic use in acute care hospitals in the United States is either unnecessary or inappropriate per the CDC. And we can get pretty involved on the methodology of calculating that, but that's something we verify on everyday practice. And here's some data on outpatient antibiotic use. We're talking mostly about inpatient, but just another reason to flagellate ourselves. The United States is up there. Even this is not absolute numbers, so you cannot argue that the United States is a bigger country. It's just per 1,000 inhabitants, we prescribe more antibiotics. Are we really sicker, or we are just scared of medical legal issues, etc.? So what we just defined antimicrobial stewardship at the beginning. So what do they actually do or what do we do when we run a program? Well, we can have a number of interventions that fall under these categories. We can restrict antibiotic use, and those are the ones that obviously result in quicker drops in antibiotic use, but not necessarily last longer. You can restrict drugs in the formulary. You can implement prior authorization that if you want to use linezolid or daptomycin, you have to call infectious diseases. You can choose selective reporting, which is a lab intervention. We know people should not be using antibiotic XYZ for bug XYZ, even if it is reported susceptible. So we'd rather not report it, so people stop using it. So those are strategies that have been used and fall under the restrictive category. We can be persuasive and, well, use plain old education. And I was a little bit skeptical about that, but in reviewing the literature for this talk, I realized there are good education interventions, and we have great opportunities to do that here with our setup. Very involved intervention that we are into presently is prospective antibiotic order review. In brief, a provider prescribes. We have a list of set criteria to go over that flag, at this point manually for the most part, but with the help of IT, this is going to flag automatically. For instance, a bug-drug mismatch. Patient has demonstrated Pseudomonas in the blood, yet they are receiving ceftriaxone. And you know ceftriaxone is intrinsically, or better said, Pseudomonas is intrinsically resistant to ceftriaxone. So that's a red flag. They should change the antibiotic. And that flags, and we communicate to the provider. In this case, we have the luxury that I've been here 4 years, so I know what their preferred way is of communicating. In most cases, a staff message, sometimes a call, a page, or whatnot. And then we give a suggestion. We don't change it for the most part, and we'll come back to that. Some of these interventions are actually pharmacy-driven. In other institutions, a lot of things just happen automatically, and they don't even involve an infectious diseases physician. You can do education in the form of prescriber feedback, like an audit after the fact. And here's some examples of structural interventions. We have some of them, for instance, rapid diagnosis, and incorporating PCR, molecular diagnosis, to speed up the identification of bacteria before the culture is back. And we'll touch base on this as actually some low-hanging things that we can do here, low-hanging fruit that we can optimize here in Mary Greeley. So you may ask, okay, so show me the evidence that this works. So we're most interested locally in the effect on C. diff rates, and you can see here an example of a hospital that looks a lot like us, other than this was a teaching hospital, but the size of the hospital is relevant for us. The team that was involved, an infectious diseases physician plus a clinical pharmacist, just as we have it set up here. They did prospective feedback, they did local guidelines, and pharmacy restrictions as well. Their process measure was that they achieved 22% decrease in broad-spectrum antibiotics over 7 years, with a very significant p-value. The C. diff rate, which is the ultimate goal, was decreased, as you can see here, from 2.2 cases per 1,000 patient days to 1.4. Now, this was coupled, and not mentioned here, with infection control initiatives, namely, and we'll talk about the importance of infection control, but gowning up, etc., to prevent the horizontal spread of C. diff within the hospital. Similar experience on a larger hospital, 834-bed hospital, similar setup. They did all these interventions that seem a bit radical. They required antimicrobial restriction for clindamycin. I mean, I can't imagine that here. When you read this article, you realize they were having an outbreak, basically, and they were very aggressive. So they achieved decreasing antibiotic use in the particular classes or antibiotics that were restricted and look at their decrease in C. diff rates. So these programs work. Now, people may ask, okay, Ricardo, great, we're going to decrease our antibiotic use. People are not going to get C. diff, but they're going to die from their cellulitis because you don't give them broad-spectrum antibiotics. Well, here's the evidence that was aimed, or that is aimed at making a counterpoint on that. This comes from a Cochrane database systematic review in 2013. They looked at all these studies to pull the data and concluded, this little diamond to the left side indicates that there was a tendency for antimicrobial stewardship interventions to be protective against mortality. So intuitively we can say, okay, these people received the antibiotic they needed, they did not receive antibiotics they didn't need, so they died less, and it makes sense. It is not a it crosses 1 for the statisticians in the audience, so it's not a real significant, statistically significant difference, but it has a tendency towards protection. It clearly did not increase the mortality. How about cost? And the reference did not show up here, and I should mention is Dr. Fisherman, if I'm pronouncing his name correctly, or Fishman, and this is straight from his lecture because I couldn't get a better picture of this study. And this is a study that showed in dollars, so here's dollars in this axis, and this other axis we have quarterly data in this hospital since 1998 all the way to 2010. They looked at what happened before the antimicrobial stewardship was started, during the antimicrobial stewardship program, and what happened after. So as you can see here, the total amount of dollars spent, despite inflation, was about holding up when the antimicrobial stewardship program was in place, only to raise again after. Excuse me. So they achieved a control of costs. Similarly, a study in Maryland Medical Center followed people for 7 years, or followed the program for 7 years, during and after, and they achieved this kind of savings per 1,000 patient days. So went down from 44,000, and this is dollars spent in antibiotics, to 23,000. So almost a 50% decrease from prior to the full implementation of the program. So if you don't want to go by evidence, you want to pay attention to the stakeholders. So federal, state, and regulatory agencies have all taken notice of the importance of stewardship programs. This comes straight from the National Action Plan for Combating Antibiotic-Resistant Bacteria in March of this year, issued by the White House. And in their very first goal, they state, well, there's a number of interventions they list there as recommendations, and one of them is that hospitals implement antibiotic stewardship programs. California is the first state, and the only, to the closing of this edition, that has mandatory antimicrobial stewardship programs for all hospitals. How about our favorites, JCAHO and Centers for Medicare and Medicaid? Well, JCAHO has been flirting with this for a long time, and they send all sorts of communications that all look like this. The most recent one, I thank Leanne Hillier for this one, just got it on the email yesterday, September of this year, and as you can see, it's a total ripoff of what we've seen on the federal document. They want us to consider antimicrobial stewardship with specifically all these elements within it, and we'll go over these elements when we talk about how we're implementing our stewardship. How about Medicaid, Medicare? Well, they have this hospital infection control worksheet that has many items. Of course, it's about 49 pages long, but it has stewardship within it. It says the hospital, it'll ask you whether the hospital has written policies and procedures whose purpose is to improve antibiotic use. That's antimicrobial stewardship spelled out there. So, second and last part of the talk is, how do we bring this home? So, what's our team here in Mary really? Well, this reflects, or intends to reflect, the recommendations by all the stakeholders I mentioned, plus the CDC, plus IDSA, that specifically have guidelines on how to do this. So first of all, they recommend there has to be a buy-in by the hospital administration, and I'm proud to say that we have an excellent buy-in from them. We have the opportunity that both CEOs from Mary Greeley and McFarland Clinic understand this concept very well, and they are on it not only for the cost savings, but mostly for improved patient outcomes, and because it needs to be done. So they recommend leadership commitment done, appropriate, that the hospital administration dedicates appropriate resources, including compensations of the personnel involved. And this is the personnel involved in the core of this program. So the program leader right here, who's going to be accountable, who needs to track the antibiotic use, report back to hospital administration, and come up with goals and actions. Coupled with pharmacy expert Gary Bailey, who actually does all the work, and who reviews the antimicrobials prospectively. And we meet regularly for this intervention that is the prospective antimicrobial review. We would be useless if it weren't by the other people in the team. So information technology is capital, otherwise Gary would be in 24 hours a day and not accomplish much. I mentioned the flags in the system, so they call it BPAs. So right now I got an email actually yesterday or a couple of days ago that they were able to build in several BPAs, like, as I mentioned before, bug-drug mismatch and similars. So Amber Deardorff, I'm going to name drop people here, has been the leader of this team, and she's been extremely helpful. The lab is important because, as we're going to see, there's a couple of things that we can do for stewardship that are really, really low-hanging fruit, that are really out there already and we're not utilizing, and they're all lab interventions. So Connie Henderson has been helping us with this. And in infection control, just for some people who are not familiar, the difference between infectious diseases and infection control, I realize some people are not familiar with that. Infection control is actually an office in the hospital, and that is a mandate of, or something in the checklist of JCO. And in our cases, there are two nurses working there, Leanne Hillier and Melissa Egland, and they take care of controlling the spread of infection within the hospital. I kept saying this this term, horizontal spread. So as you realized, putting things together, the stewardship, what it does is trying to prevent the development of resistance on the first place. But when somebody comes in with a CRE, they're the one supervising that this doesn't spread within the facility. So in the case of C. diff, this is extremely important. We need to work together. And last but not least, prescribers and nurses are in the loop. We need to communicate back and forth with you guys well, you're the ultimate prescribers. So the intervention is on you. And the last thing we want with this is that it becomes another thing to click in Epic or another thing to be ding about. We want this to be understood as it is, which is we're here to help you provide better care for your patients in what pertains to antimicrobial prescriptions. So we need to look at our local data to come up with our goals. And here's our goals. So C. diff, one of our hazard level urgent organisms, is higher than expected at Mary Greeley Medical Center. Not horribly higher, but higher than expected. This number means the standardized infection ratio, which is nothing but dividing observed over expected cases, in this case C. diff. So we got 9 in this particular quarter, 2013, quarter 3. They were expected 6.8, and we can talk about the methodology on how do we expect to have those. It's based on what happens elsewhere, of course, and what is expected for a size of the institution, etc. So you see all these red flags here. Statistically, is not significant in most cases, but clinically, we don't want to have any C. diff higher than we should. We want to have 0 C. diff, actually, right? So the multiple organisms that I mentioned at the beginning that are labeled as serious threat and whatnot can be, most of them fall into this convenient mnemonic coined, I think, in 2009, ESCAPE. So VRE, MRSA, CRE that we talked about. The K is for the gene KPC, the most common gene determinant CRE in the United States. A for multi-drug resistant Acinetobacter, multi-drug resistant Pseudomonas, multi-drug resistant Enterobacter, not to be confused with Enterobacteriaceae. We're talking about the genus Enterobacter. So good news here is that we're still low-key, and these are absolute numbers. So as you can see, we had 1 CRE, we had, I'm counting here only MRSA bacteremias. If we counted colonization, that would be much higher. But I'm trying to make the point here, even though we are aiming at decreasing the emergence of these organisms, I think a more immediate goal is lowering our rate of C. diff. So let me propose this goal. And the way I would like to go about this is, as you will see, there will be plenty of opportunity to discuss back and forth with providers. But I think with the evidence, we can conclude that this is a reasonable goal, to reduce the rates of C. diff by reducing unnecessary broad-spectrum antimicrobial use. Particularly, and the next slides will show you why this particularly, broad-spectrum penicillins like ampicillin sulbactam, piperacillin tazobactam, aka Zosyn, and carbapenems, coupled with optimized infection control practices. So this is in beta version. I want to discuss it with you guys in multiple instances. So let me paint the picture with a patient who actually was here not long ago. Why do I think this is a way to go? So this is a case of unnecessary broad-spectrum antimicrobial use in non-diabetic soft tissue infection. So cellulitis on somebody who does not have diabetic foot ulcer. Diabetic foot ulcers are a separate thing. I mean, it might be a soft tissue infection, but these guys get multi or polymicrobial infections there. But when we're talking about plain old cellulitis or bursitis or even septic arthritis for that matter, in without that setting, usually we're talking about gram-positive bacteria, period. Okay, so with that background, this is a case of a 36-year-old man who suffered blunt trauma to the knee at work. Actually, he had repeated bumping of his knee, the way he was sitting there. He came 1 week later. His knee was swollen. It was erythematous. He had fever and chills. His blood cultures, not mentioned here, were negative. So the initial diagnosis was cellulitis, and he was prescribed vancomycin IV. By day 2, the erythema was worse, the swelling was worse, so he was added piperacillin tazobactam, aka Zosyn. By day 3, he had developed acute kidney injury and nausea. And this persisted into the subsequent days. And that became actually his main issue. That day, orthopedics was consulted, and only then they diagnosed bursitis based on the clinical exam and the history. They proceeded with drainage, and lo and behold, there was MRSA. No gram-negative rods. Further, this was an MRSA susceptible to all these antibiotics. So ID was consulted. We switched to clindamycin IV, and the decision to do that was based on the fact, well, vancomycin is hard to, it probably perpetuating the acute kidney injury, probably was part of the acute kidney injury. Let's just switch to clindamycin, which has the advantage as well to be able to switch to PO later. His hospitalization ended up prolonged for the issue he came in with. So by day 7, he was not completely done with his acute kidney injury, but he was clearly getting better. He was tolerating PO. We ended up switching to PO doxycycline because he did not tolerate well the clindamycin PO, and this, despite the fact this antibiotic may cause some GI upset as well, it was well tolerated. So, teaching point there, if you wish. Gram-negative rod coverage rarely is needed in cellulitis. Only if there's specific exposures. I set aside the diabetics, but we're talking about rather rare situations. Cirrhotics tend to get B. vulnificus, but even only if they have certain exposure to seawater, for instance. Aeromonas and pseudomonas are frequent when you have a wound that is exposed to lake or river water. And I've seen also gram-negative rod cellulitis on somebody who was just very dirty and had gross stool contamination and an open wound. So except for those cases, you really don't need it. So what is the intervention? And I wanted to show this was a work in progress. This is a copy paste from my working document. So why don't we develop a local pathway? Okay, and this could be an order set. Again, the last thing I want to be a take-home message here is, okay, I'm going to get another thing to click on an Epic that is just something else that's going to build up to my workload. We don't want it to be that way, so it can just be a reminder. It can be hanging out there in Jostle, for instance, or in your email. We'll come up with that. But the point in case is that there's a number of interventions that could become standard for cellulitis. Blood cultures. 10% of cellulitis do have positive blood cultures. Many times we run into blood cultures not drawn or drawn ×1, which brings up the issue of contamination. Is there any drainable site? Very relevant in this case. If that, I mean, hate to be Monday morning quarterback, but that's a teaching point of this case. You want to make sure they don't have anything to drain, because that is the treatment when you have an infection by Staphylococcus aureus that has something to drain. This has been done non-systematically, and I think it's great. People are taking photos when the patients first come in, and that helps tremendously when some other provider comes into the case. And it does not need to be done by the physician. It can be done by the staff. By the same token, markings or measurements, etc. We can have within those guidelines in some format listed all the risk factors for MRSA as opposed to MSSA. We can have the risk factors for gram negatives, so people have a quick reference in the point of care. And then we would have built in our order set or pathway our preferred antibiotics for cellulitis, and following guidelines and following evidence. Briefly, since this is not a cellulitis lecture, cellulitis can be divided in non-purulent and purulent. When it's non-purulent, when there's nothing to drain, when there's no pus, this is going to be almost for sure Streptococcus, and therefore the antibiotics listed there are appropriate. If it's purulent, or if the patient has recurrent MRSA, for instance, you may want to cover for MRSA, and the antibiotics of choice are listed there. Writing a clinical pathway or guideline would do nothing if we don't enforce it, and also complemented with other interventions that really bring this to the daily practice. When early education interventions have been done, they were more like in the lecture format. Like, if this were my intervention, is extremely not efficacious. So all these things that you see here are opportunities for efficient adult education. So prospective antibiotic review, as we mentioned, we go over that. We sit every day. If you see Gary and me sitting in the doctor's lounge by noon, that's what we're doing. So watch for us. So we'll flag all patients with non-guideline antibiotics, hopefully with the help of IT. And then we can come up with this. I didn't consult with Dr. Fulton about this, but I think he'll welcome the business. While we're working on this particular goal, why don't we bring in ID to the cases more frequently, particularly when flags like this are present? Like, I think this patient needs ampicillin, or it was already given. So ID can come in the case and say, okay, this is okay, or this is not. And there are other, I mean, this escapes a little bit the goal that we said, but if we're going to build a guideline, it needs to consider the whole care of the patient. So there are other cases that may need an ID consult for cellulitis. For instance, if there is bilateral cellulitis, quote unquote, which 90% of the time is not cellulitis, recurrent cellulitis, refractory cellulitis after days of treatment, immunosuppressed individuals, in oncology, for instance, etc. And lastly, this is our little project of the occasion. I think we have a great opportunity with this collegial environment in McFarland and Mary Greeley, the geographic proximity, the fact that I'm no stranger to people here, been here for 4 years. Most people don't hate me. So I can just go do this itinerating lectures or focus groups where with key people for this diagnosis. So we hope that such a comprehensive intervention finally achieves the goal. Okay, there are low-hanging fruit of antimicrobial stewardship that needs to be done just because it's there and it's the appropriate thing to do. And that is the same here as in other institutions. So IV to PO conversion. Antibiotics like levofloxacin, metronidazole, fluconazole, they're 90% bioavailable by mouth. So the criteria are easy. The patient is taking their pills, they're not vomiting, they are getting better also. That is another criterion that we have. Well, so be it. Let's change it to PO. And in many places, large educational or teaching hospitals, they actually do it automatically. Pharmacy does it. They don't even get back to the physician. Just to get the point straight that we're not just trying to reduce antibiotics at all cost, this is also about getting people the right treatment. One thing that we have observed occasionally is that ceftriaxone is underdosed in meningitis. So the dose for ceftriaxone in meningitis is higher than for most diagnoses. It's 2 grams IV Q12. I'm sorry, that's a big typo there. Don't take that home. 2 grams IV Q12, okay? And unless there is a severe liver kidney failure going on, there's no reason why the patient should not be on that dose if you are committing to a diagnosis of bacterial meningitis. So this could even be a pharmacy changed intervention. At the beginning, we're trying to just go slow with that, be cautious, you know. We don't want to be too intrusive. We want to make sure people understand we're here to help and get the better care for the patient. But I mean, for such a critical thing, we may start changing this early automatically. And let me touch base just towards the end of this lecture. Part of our low-hanging fruit here is using what we already got. We have an excellent tool that, honestly, when I started treatment, I didn't think this was going to be available routinely, let alone in a community hospital like ours. So you may have been seeing, I'm sure you've been seeing this type of results when blood cultures come out. In addition to the regular blood culture, typically 24 hours before it is actually reported, you get this kind of report. What is this? This is molecular identification of organisms. So certain organisms we have probes for, so we can literally go fish for the specific organisms and identify them essentially 24 to 48 hours prior to the traditional methodology, the traditional culture report. This has been in-house, I want to say, for a year. People may correct me from the lab here. So this is invaluable because we get this type of high-quality information, and this is 95–99% accurate in most cases. We get, okay, we already know 24 hours later that we have a Staphylococcus species that is not aureus. Well, if you know a little bit about it, that's probably a coagulase negative staph. And it has a MEK-A gene. So what is that? That is the gene that confers resistance to methicillin. That is the gene that makes MRSA. But in this case, they already told you this is not a Staph aureus. This MEK-A gene is present on a Staphylococcus coag negative. So this is by all means a coag negative Staphylococcus. It's typical for coag negative Staphylococcus to have the MEK-A gene, so this makes sense. If you were to treat this, you know you cannot use beta-lactam because it has the MEK-A gene, it has methicillin resistance. You need to use vancomycin. But in this particular case, this grew in only 1 out of 4 bottles, namely in the anaerobic bottle of 2 sets. So with this information and with a clinical picture of the patient, I was confident to tell, okay, this is a contamination, let's not treat it. And long and behold, this ended. This is the most typical result that you are accustomed to see. So Staphylococcus coag negative, Staphylococcus epidermidis specifically, grew only in the aerobic bottle, not shown is the other set, so this is 1 out of 4 bottles. And it was a contaminant by all means. So there is similar reports for, you're able to identify MRSA early this way. You are able to identify ESBL, extended spectrum beta-lactamases, early. So this is an invaluable tool. So as you can see, it just doesn't take this few minutes of me talking about this to make this happen. This, when it comes out, is confusing in EPIC, particularly if you're used to see it a different way. I've been tricked by this result because it comes out and it looks like it's just a 3rd bottle drawn or a 1st set drawn. So we need to work with IT, we need to educate physicians. There's all these interventions that need to happen for this to be clinically useful. So in conclusion, antimicrobial stewardship programs are evidence-based, institutional, systematic interventions to optimize antibiotic use. They have been proven, there's empiric evidence that they reduce adverse events, including C. diff colitis. They reduce the emergence of resistant organisms, MDROs, and improve patient outcomes in the process. They also achieve cost savings, as we have shown, and we should know that stakeholders want us to do this. One thing not mentioned in the slide that came later when I was preparing this is that I asked Leanne Healer in the hospital to kind of survey people who is doing this where, and turns out that most hospitals are doing something. Out of 19 hospitals that were asked in Iowa, and most of them were up to something, either talking about it or running a program already, a pharmacy-driven one. The hospitals in Des Moines do have an infectious diseases doctor and a pharmacist working together. So I'm glad we got up to speed with that, and your input on this as we go is invaluable. Remember, this is here to help you take better care of your patients. So, questions? Yes, sir.
You mentioned quinolones as one of the police drugs potentially in the hospital. We use a ton of them in the outpatient environment. I wondered if you could speak to how this whole effort will impact the outpatient management of infectious disease.
Sure. Well, 2 things about your question. Well, first of all, that was mentioned as something that was done in a different hospital. We don't need to replicate what they did. I think you caught it in this one, right? They were in an outbreak situation for C. diff, and they were desperate times called for desperate measures. I believe it would be counterproductive to recommend we don't use levofloxacin, that we restrict levofloxacin. That's a very valuable antibiotic. So that speaks to the point that we're not here to say no antibiotics. That's not the spirit of this. Good antibiotics need to be used for the right reasons, right? So I guess I'm answering to your question by saying, okay, that's not within our plans, not anytime recently. The second aspect to your question is that you bring up the issue of continuum of care, right? So great, we do all this in the hospital, but things happen in the clinic too, and people do get antibiotics there. Clinic antimicrobial stewardship is in its infancy. When you go to Infectious Diseases Society of America meetings, they've been talking about that for years, and things don't really move forward, and we can pioneer that, but the challenges are that how do you keep track of things? In the hospital you have everything under a roof geographically, electronically, and things are happening on a daily basis. The clinic is a little bit more spread. So, but I think it is important that we eventually get there. And one way we're going to address clinic antibiotics is by educating physicians. I think, as I had mentioned, we have a unique opportunity. The body of physicians here is the same as in McFarland for the most part, and education in one place affects the outcomes in the others. So I have no intent of cutting off your levofloxacin, Dr. Brown.
I didn't mean to sound
Sure. Now, I know you. May I mention something you do that I think should be brought forward for the clinic? I mean, you use a lot of dicloxacillin, right? Which is a very narrow penicillin. And I think, including myself coming from Detroit and Chicago, I had a cultural bias of not using that type of antibiotics. Just because, because things are resistant there. But I think that's something we can learn from you in the outpatient setting. Yeah, so no intent to cut off the level.
We use tetracycline and doxycycline for rosacea around the eye and severe blepharitis, not for its antibiotic effect, but for the anti-inflammatory effect. Sure. Do you think that needs to change? Does that contribute to resistance?
Boy, topical antibiotics used in other settings, even antibiotics in animals, you find all those topics in all these reports that I had mentioned. It's in the White House statement, it's in CDC. I mean, those are those are necessary things, I mean, that's the standard of care.
But we use oral tetracycline and oral doxycycline.
Okay, yeah. Okay. And is that a standard of care thing, or part of my ignorance?
We've been doing it for 20, 30 years.
Okay. So I guess in a scenario like that, yeah. So things like that, for instance, what we can help with is reviewing the evidence. Going back and say, okay, are we doing this, as I said, just because it's the culture and we think it works? I mean, it might be the best level of evidence to say, okay, I have experience on it or with it, and pathophysiologically it makes sense, so let's do it, and that might be the best level of evidence available. It all comes down to what antibiotics are appropriate, and what is appropriate is determined by evidence, and I'm ignorant on that particular diagnosis, so I couldn't speak to that one, but that's the general way I would address it. Yeah. In general, tetracyclines have low association with C. diff, for any consolation. So.
Ricardo, you talked about maybe in the doctor's lounge talking to physicians, but as you can tell, there are not that many primary care physicians here or oncologists here. Do you have any other thoughts as to how we can get their attention to have a little more education?
Yes, sir. So I think the key is taking the show to the road, go to them. I plan to hijack the meetings that are already in place in the clinic. Okay, next month we're going to have Arbulu talking about this. Or more than that, the spirit is we are going to talk about this. We are going to review the guideline for cellulitis. So this guideline that as I said, I copy-pasted from my own scribbling here, on purpose I put it that way because I want to show this is a work in progress, and I plan to go to the stakeholders for this, where family medicine, adult medicine, and say, okay, what are your thoughts on this? I mean, people do have valuable thoughts on this, and they have a practice, you know, they're used to do things one way for a reason. At times it's just culture, and at times it's evidence. So bottom line, Dr. Kittle, I would go to them. That would be the #1 answer for your question, and present that, okay, this is not me coming to police you. I'm not here to ding you or, you know, hold you accountable. I'm here to help you facilitate a discussion on this topic. I think that's how I would present it.
Dr. Arbulu, thank you for a good presentation. I have 2 questions. First is, what do you think about prophylactic antibiotics when sometimes using to prophylactic surgical patients, like a few doses? And the second one is the use of antibiotics in domestic animals. Is it effect on use of antibiotics in medicine?
Yes, ma'am. Thanks for the 2 questions. So #1 is surgical prophylaxis is a standard of care. There are indications, there's evidence, there's guidelines. So all we need to do is make sure we follow those, right? There are opportunities for improvement in that area as well. Excuse me. And it's all about having standards. It all comes down to that. I mean, there might be physician preferences in, unfortunately, in this stage and age, there's little room for physician preferences just because we like it. You know, we need to abide by the evidence because we're getting held accountable to that, and because not abiding to evidence has consequences. Just quickly, an opportunity there would be, for instance, the penicillin allergics. A lot of people are labeled penicillin allergic, and I got a patient who was, quote, penicillin allergic, and she got clindamycin for surgical prophylaxis because she couldn't get the standard cefazolin, and she got C. diff. So could we have prevented that C. diff by doing a better history on penicillin and finding out what was the case, that she was not really penicillin allergic, right? So that I wanted to find an excuse to talk about that because you gave me opportunity for that. Bottom line, standards of care is the answer. And your second question, when I was answering Dr. Kangas, I was getting to that point too. And I'm no expert on that part, but it appears to be that antimicrobial use in animals is also part of the problem. So it has contributed to increase the resistant bacteria. All comes down to selective pressure, and I hope I have a slide on that. There you go. So this process happens in humans, this process happens in animals, and is a very basic way in which resistance happens. I mean, these animals are getting antibiotics. There's naturally occurring resistant bacteria there, but they're not in important amounts. But by giving them antibiotics, these resistant bacteria become more prevalent. And some of these bacteria can communicate to each other. So if we get contaminated with XYZ fluid from an animal, we can get those bacteria, and they further can communicate with our bacteria and promote resistance. So, and this is as I said, I'm no expert on the animal part, but even in the White House document you find verbiage on the importance of controlling antibiotics in animals. So that's a current issue as well. Thank you.